This is the second half of the schizophrenia lecture. Well, actually, it's the middle of three, right? The nursing process. Well, remember, your nursing process starts with assessment. That's when we're going to be getting all of our cues, all of our history. Our diagnosis is not the medical diagnosis, it's the nursing diagnosis. These can range depending on what you get in your assessment, will guide what your nursing diagnosis is. After we get our diagnosis, we want our outcomes, right? What are our goals for our client and what interventions can get us to our goals? After we get that, we're going to do our implementation, which is our action phase when we're actually implementing those interventions that we planned. And then we follow up with an evaluation. Is what we planned as an outcome the outcome we actually got? If so, great. If not, what can we do differently? Things that you want to assess on your schizophrenic patient, you want to know their medical history. At what age was their onset? We know that, for men, 15 to 25, for women, 25 to 35. Those are the peak incident onsets. Um, any client with mental health, any client period, we should be assessing for suicide history. Have they just thought about it? Have they attempted it? What current support systems they have in place, what's their perception of their situation, what's their general appearance look like? Are they appropriate for the situation? Are they not appropriate? Are they having bizarre behaviors? Are they moving inappropriately? What's their speech like? Um, are they having delusions? Are they having hallucinations? So more about speech. I know this is kind of small for the lecture online. You can get all of this from your book, box 16.3. Just to discuss a few of these, clang associations are ideas that are related to one another based on sound or rhythm rather than on meaning. So an example would be, I will take a pill if I go up a hill, but not if my name's Jill and I don't want to kill. Means absolutely nothing, but pill, hill, Jill, kill rhyme. Neologisms are words invented by the client. They have no meaning to regular society. They only have meaning to the client. Very often, the client will repeat them quite often. An example is, I'm afraid of Grizzy. Is there any Grizzy here? I will have to leave. Are you Grizzy? Echolalia is when a client has repetition of what is being said to them. So if you, the nurse, say, "Can you tell me how you feel?" Then the client just reads, "Can you tell me how you're feeling? How are you feeling? How are you feeling? Tell me how you're feeling." Stilted language is when they're kind of flowery, they're excessive. Um, an example would be, if you're a nurse and they want to ask for a drink, rather than saying, "Can I have a drink?" They're going to say something like, "Would you be so kind as a representative of Florence Nightingale to do me the honor of providing me a wee bit of refreshment, perhaps in the form of some clear spring water?" Word salad is another one. That's kind of a combination of jumbled words and phrases. They're completely disconnected from one another. They make absolutely no sense. An example of that would just be corn, potato, jump up, play games, grass, cupboard. Moving on, other things we want to assess. We want to assess the patient's mood and affect. Are they related? Are they appropriate? Is your patient saying that they're sad and yet they're laughing? Are they saying they're happy but they're crying? Um, Different thought processes. Are they withdrawn? Are they having delusions? Are they having hallucinations? One thing with hallucinations, if they're having auditory hallucinations very frequently, mm, they might they might realize, they might not realize, but they're usually looking around for where the noise is coming from. So they might have darting eyes, tilted head. They might be mumbling to themselves to answer what's being said to them. Usually, as I've said before, auditory hallucinations are not nice, happy, positive talk. Usually, auditory hallucinations are um, negative things, and we need to assess for that because if the auditory hallucination is telling the patient to hurt themselves or kill themselves, we need to know that so that we keep them safe. More about delusions. Delusions are false fixed beliefs. We can have persecutory or paranoid. These are when clients believe that others are out to get them. They're talking about spies. Um, they might not be able to define who these people are that are coming for them. Grandiose delusions are characterized by claims of being associated with famous people or that they're just wonderful and great and all powerful. I've had a lot of clients in the past with grandiose delusions. Um, a lot of times they know people that are going to get you fired. Your religious delusions are usually Christ-based religious figures, prophets. Um, an example of that would be the client claims to be the Messiah or a prophet sent from God. When we talk about somatic delusions, these are generally vague. They're unrealistic beliefs about the client's health or body function. Um, they might tell you that they have worms in their brain. And you might think, I'm going to do a CAT scan and I'm going to show them the images of their CAT scan. And they're going to then see that there are no worms in their brain. And you can give them all the proof in the world. It's not going to stop that false fixed belief. Sexual delusions involve the client's belief that their sexual behavior is known to other, um, that the client's a rapist, a prostitute, a pedophilia, they're pregnant, they have excessive masturbation. We want to test their judgment and their insight. Judgment is frequently impaired with clients with schizophrenia because judgment is based on the ability to interpret the environment correctly. If follows that the client's disordered thought processing and environmental misinterpretations will greatly impact their ability for proper judgment. At time, their lack of judgment can be very severe, that it can affect their safety and their protection to keep themselves out of harm. Things might be failing to wear the appropriate clothing, not being able to seek the appropriate medical care. Insight can also be severely impaired, especially early in the illness. And the client might not understand what's happening. They might not be willing to seek medical attention or assistance. Self concept, deterioration of self concept is a major problem with schizophrenia. Clients may believe that, you know, they're fused to another object, or they might not have a clear sense of their own body or their own mind. They might have some body image distortion that's occurring. Lots of bizarre behaviors that can lead to public undressing, masturbation in public, speaking about oneself in third person, or physically clinging to objects in the environment. With roles in relationships, social isolation is prevalent in clients with schizophrenia. This is as a result of the positive symptoms like the delusions, hallucinations, and loss of ego boundaries. Relating to others is difficult, especially when their self concept's not clear. Clients also have problems with trust and intimacy. These clients can lack confidence, feel strange or different from other people, and do not believe that they are worthwhile. This also results from them avoiding other people. Um, Family roles, fulfilling family roles like being a son, a daughter, a sibling is difficult for these clients. That they're often erratic, they have unpredictable behaviors, they can frighten family, embarrass family members. Family members can sometimes feel guilty or responsible. These clients may also believe that they have disappointed their families because they cannot become independent or successful. Moving down to self care considerations, clients with schizophrenia have significant self care deficits, especially when they're having a psychotic episode. They might be so preoccupied with their delusions and their hallucinations that they fail to perform basic activities of daily living, such as showering themselves, changing their clothes, brushing their hair, eating. So, what types of nursing diagnoses? Well, you might do a risk for violence if they're psychotic. Um, you might want a risk for suicide if they're having command hallucinations. You might have a self concept. You might have um, personal identity disturbances, impaired verbal communications, hallucinations, delusional thinkings. So, when we're planning our outcomes, number one, keep the client safe. Truly, number one is keep yourself safe. If you get hurt, you're not going to be able to care for the client or care for anybody else. Next, we want to make sure that we're keeping the client and everybody else safe. We can do um, helping them with interacting with the environment, helping them express thoughts of feeling safe, socially acceptable, adherence to intervention. Some actions. So, when we're promoting safety for the client, we might want to use the establishment of the therapeutic relationship so that we build trust. We can use our therapeutic communication to clarify their feelings and statements. If they're having delusions, we do not want to openly confront them about their delusions. We do not want to get in an argument or a power struggle over that. You want them to tell you about their delusions. You want them to tell you about your hallucinations so that you can help with distracting techniques. You can keep them safe. More stuff for the hallucinations. You want to help present and maintain realities by frequent contact with them and communication with the client. Don't want to just put them inside solitary confinement if they're having active hallucinations. And again, by you understanding it, it's going to help to keep them calm and reassure them. Sometimes we can engage them in reality based activities like playing cards or occupational therapy, even listening to music. We can teach them coping skills so that they can have more social appropriateness. If they're having some inappropriate behaviors, we're going to want to make sure that we redirect them. We want to make sure that as we're redirecting those inappropriate behaviors, that we're doing it in a non-judgmental manner. And remember, when we're talking about non-judgmental manners, we're not necessarily approving them, but we're also not berating them for what they've done. We want to make sure that we're reassuring them. We want to try to help them to interact with others as possible. We can do some teaching and education about social skills. We can role model good behaviors with them. Sometimes we can do communication where we actually practice having conversations with them. We want to teach the family coping skills as well. We want to establish community support systems and care so that way they have that when they get out. A little bit more about client and family education. So it's really important that we catch a relapse when it first starts. The next slide is going to be early signs of relapse. We can do one-to-one activities between the nurse and the client to promote relationships. Um, Nutrition and self-care is important. Again, clients with this disorder, especially if they're psychotic, they're going to pay little attention to their hygiene. They might not be eating. As the nurse, you can direct them in short, simple, clear tasks to aid in their ability to actually get them complete. So, what that means is you're not going to say to them, okay, it's time to wake up, brush your teeth, take a shower, get dressed. No, we're going to say, okay, it's time to wake up. They're going to wake up. All right, here's the toothbrush and toothpaste. Let's brush our teeth. Teeth are brushed. Now we're going to take a shower. Let's wash our hair first. You're going to break it down into simple, clear tasks. Um, you want to make them part of their daily routine. Obviously, if somebody's really psychotic, they're not going to be able to do all the tasks. You might have to help them wash up and clean up, but you still want to promote good self care. Clients might forget to eat. So it's really important, especially when they're psychotic, that you're noting what they're actually getting for nutrition and ensuring that they're getting some type of nutritional value. Financial funds can sometimes be hard, so we want to get them in community resources, get case management involved. We might have medication management systems, so that way they can get their medications. Um, and then the last stage is the evaluation phase. We want to make sure that our goals were met. So, if you're doing some type of inadequate nutrition, right? Taking it back to, nursing, your med surge nursing, right? We would want to set a nutritional goal. We would want to monitor that maybe by them gaining weight or not losing weight. And you would want to do like, do we do daily weights? Do we do weekly weights? Right. And then after we practice this for a week or two, what's our evaluation? So, this box just talks about signs of relapse. Um, if the client's starting to have lack of sleep, if they're starting to report fatigue, mood swings, irritability, difficulties with interpersonal skills, low self concept. This is some information about client and family medication management. Uh, some of these medications can have an anticholinergic effect. We'll talk about that a little bit more when we get into medications. But when to keep them more compliant, we need to make sure that they're tolerating the medications as best as possible. So if they're on some type of anticholinergic, they're going to have effects of dry mouth. And these medications can also lead to weight gain. So it's really important that we're, educating them about low sugar drinks or sugar-free candies, and we want to avoid extra calories um, by doing things like soda. We also want to make sure that we're not having a lot of candy because that can do dental issues. When they're having cholinergic effects, they can also have constipation. And we'll talk about a lot of this more when we get to the medication part of the lecture. True or false? The nurse should confront the client's delusion. False. When the client is experiencing delusion, the nurse should focus on reality and not confront or reinforce the client's delusion. And again, if the client's having delusions, you want them to express what it is. So you want to listen to that delusion. Um, Same thing. If they're having hallucinations, you want to figure out what they're hallucinating. Because if they're hallucinating something or they're having delusions of something that could potentially put you at risk, them at risk, you're going to need to modify their plan of care to keep everybody safe. Some age relating considerations. Again, um, it's rarely seen before the age of 5. Um, In children, it's usually characterized by delusions and hallucinations, as well as deterioration in functioning. Delusions must be distinguished from childhood fantasies, and abnormalities of speech and behavior differentiated between developmental slowness or intellectual disability. Late onset schizophrenia refers to when it's developed after the age of 45. Schizophrenia, if not initially diagnosed in it's not typically diagnosed in older clients. Psychotic symptoms that appear later in life usually are associated with depression or dementia, not with schizophrenia. People with schizophrenia do not survive into old age with a variety of long term complications. They have increased risk for developing dementia. Approximately one-fourth of clients experience dementia, resulting in steady deterioration, decline in health. Another 25% actually have a reduction in positive symptoms, somewhat like a remission. Schizophrenia remains unchanged in the remaining clients. Late onset schizophrenia refers to that greater than 45. Um, this is everything that I just said. So, yeah, we're not going to repeat it. Okay. Community based. Community based care. So, the hospitals are trying to reduce the amount of time that clients are actually in house. Um, so, with that, we've tried to develop these community based services to help provide the client and the family with support. This can be independent housing, it can be residential or group homes that have the additional services. We can have like medication people that will help ensure that the client's medication is refilled, brought to them so that they don't have to find a way to get it. Um, what else is here? Case management services often include helping the client with housing, transportation, money management, keeping their appointment, as well as socialization and recreation. Common concerns of clients include difficulties with treatment and aftercare, so dealing with psychotic symptoms, environmental stresses, and financial issues. Um, Healthcare promotion. So, psychiatric rehabilitation has the goal of recovery for clients with major medical illnesses and goes beyond symptom control and medication management. Working with these clients, we want to ensure that they can manage their own lives and that we're effectively treating and we're providing an improved quality of care. This has to be from the client's viewpoint. We want to make sure that it's central. Um, some strategies that we can use is fostering their ability for self empowerment, helping them improve their coping mechanisms, helping to improve their resilience. Again, we want early identification and treatment. So, providing that education on when relapse is going to happen is really critical. Self awareness, remember, working with these clients can present many challenges for the nurses. We need to make sure that we recognize clients that are suspicious and paranoid. Um, it's not a personal attack against us. And sometimes we are frightened. We don't necessarily need to feel frightened, but we need to take measures that our safety is ensured. We want to focus on keeping the client safe and out of the hospital. Um, the more that they're in those outpatient settings, the decreased frustration that can result with clients with chronic illnesses. Remember that the client's remarks are not directed at us personally, but are a byproduct of their disorder. Um, we need to discuss issues with more experienced nurses for suggestions. We want to make sure that we're staying open and unbiased, that we're using non judgmental. If we are truly, genuinely frightened or threatened, that the patient is or the client is hostile or aggressive, we need to know our facility's actions of what to take so that we're safe, who we're going to call. These are the key points to the chapter. You can find these in your book. There are several of them. I'm just going to put them up and you can read them. And that is the end of this one.